Thank you very much, Rachel. So yeah, I will just share my screen and give a bit of self-introduction, perhaps. So both Santosh and I are from the Health Economics Unit. We are a team hosted by the Midland and Lancashire CSU, and our mission is just to deliver world-class health economic research that really delivers social impact. So I'm a health economist, and Santosh, do you want to introduce yourself?
Hi, I'm Santosh Kumar, and I'm a lead data scientist at HE.
Okay, thank you so much. So today we're gonna deliver this talk on understanding the aging patterns in Northwest London, and this is our flow. So introduction, methodology, findings, and discussion. So let's kick off. So we all know as England enters the aging society, it's very natural to predict that future demand for healthcare needs will increase. Why? Simple reasoning, because healthcare needs increase with mobility and mobility increases with age. However, recent research, especially from the Real Center, shows that this might not be the case. That increased longevity alone doesn't necessarily translate to higher health care needs because older people can stay healthy for longer. So the more critical driver behind the healthcare needs is actually the trajectory of mobility. Mobility here means the periods of ill health that people experience. So what are the possible trajectories? So if we look at the literature, there are three possible ways. So I will walk you through it one by one. The first is the mobility expansion theory. It argues that increased life expectancy will lead to higher healthcare needs. So here, let's look at, in the right-hand side, you can see the figure. Let's look at A and B. So A represents the baseline scenario where people start to experience disease around 60 and they die around 70. That was the scenario in the previous several decades. And people, they don't live as long as we do now. And the mobility expansion theory corresponds to figure B, where people still start to experience mobility around 60, but they live up to 80. So which means a longer proportion of their lifetime is going to spend in ill health. And because of that, naturally, we would expect them to have higher healthcare needs. However, the mobility compression theory argues the opposite. They posit that people actually start experience disease at a later stage of their life. So even if they're living longer, they still live like till 80, the proportion of their lifetime spent in ill health is actually smaller. So the overall healthcare needs might decrease as a result. And there is also another theory called dynamic equilibrium theory, which seeks to balance the two. So this theory posits that people start to experience mobility around 60 and they die at 80, but they experience a milder form of mobility. So who knows, the healthcare needs may increase or decrease. We really don't have a lot of empirical evidence on that. So if we look at the empirical evidence, the result is a mixed picture. We have evidence supporting both expansion theory and compression theory. So if we look at the latest Health Profile for England report, we can see that even though people's life expectancy has increased a lot, their healthy life expectancy, which means the period of time that people spend in good health, actually has stagnant since 2012, and it's quite similar between males and females. So that would lend support to the mobility expansion theory because people are living longer, but they are not necessarily living healthier. On the other hand, we have international evidence supporting the opposite. This is because both that people were experiencing the declining trends of disability since the 1980s, and also because of the success of public smoking cessation program. So overall, the people may experience mobility at a later stage of life. So in order to find out what's the case in England, we use this data set from Northwest London, and we want to explore when the onset of having two and more long-term conditions happened, and how they change over time, and whether the patterns differ by gender, ethnicity, and deprivation. And if it does, how does it differ? So that's really as the backdrop of the story. And now I will pass over to Santosh to walk you through the methodology behind it.
Yeah, thank you. So to doing this, we adopt the survival analysis. Before the survival analysis, I would like to explain about the data source. So we worked on the Kent integrated data set, and this particular data set is a longitudinal data set. It means a particular patient has a number of entries according to the time duration. So the time duration we choose like from 1st of January 2015 to 31st of December 2021, and we only include the patient who are aged like 65 or older than. And then the key variable, if we talk about in data set, then of course our outcome variable, that is like a number of long-term conditions. And we also have demographic information, for example, patient age, their gender, their ethnicity, and their IMD decile. And then year of age means in which year they have an entry in the database for particular long-term conditions. So this is like how our data set is look like, or how is the cohort is look like here. So we have, as I mentioned, we have a data from 2015 to 2021. As you can see, 2015 has the largest cohort size there, and the patient age is varies from 65 to 90. But if you look into the 2016 to 2021, then the patient age is like only from 65 to 67. So it's like we have a quite of variation in age of in 2015, but is a very similar kind of new patient admissions or the entry in database from 2016 to 2021, and is like as the people is like in the first cohort passed away or move away in the northwest London, then every year around 20,000 newly patient turned 65 old enter into the database, which is like a 7% of the final population. So this is like more we can explore here. As you can see, in 2015 we have around 300,000 patient, and in 2016 the new patient admit like 20,752, and in 2017 21,972, and into 2020 24,888. So the largest population we have in 2015. And if we look here, then our total population is around 40,000 people are there, patients are there. Among that, like in year 2015, we have around 250,000 patients, and then in next year 19,887 patients are left, and we don't know the reason why they left, whether they died or they simply dropped from the study. And in this like year 2027, again only 21,260 patients are left, and still we don't know the reason why this happened, because the northwest the Kent data set is not like specify whether the patient is died or they died or they simply left the study. And this is now the gender distribution of these patients. So for example, in 2051, we have a 53.9% of the female population, and then 46.1 is male population, and their age median is 73. So if you look into the age median, these are like not very significant difference between 2015 to 2021. So over the year, the sex ratio and the average is quite stable. However, is underlying age structure change, there was an increase of the population after the age 85 plus years. And the cohort 2051 has aged 7 years by 2021. It means that 20% of them either died or move away from this study. Now, let's talk about the methodology or the analytical approach which we applied. So, as I mentioned, we have done the survival analysis and look into the specific 2+ long-term condition, who's gonna have a 2+ long-term condition, and how these 2+ long-term condition is expand along the time. So because we have a time and event, so the suitable methodology is for the survival analysis. Survival analysis is also known as the time to event analysis, which is referred to a set of method of analysis in which we have a length of time until the occurrence of well-defined endpointed interest. So basically in survival analysis, you can ask like which fraction of population will survive past a certain time, and at what rate will be the certain event will happen, and do the certain factor affect the probability of the survival. So these kind of questions we can answer and we get the answer from the survival analysis. So typical example, if I am giving, if you recently, for example, if you visited one dental clinic for your filling, then the survival analysis can ask like how long that filling can work for a particular patient. So for some patient, the filling can work up to the 6 year, and the other patient is filling can work for up to like 7 or 8 years. And also this filling is depend on the material, which kind of material they are used. For example, if they are using the A material, then the filling can last for 6 years. If they are using B kind of material, the filling can long like a 10 year. And also you can get the answer like whether there are other factors which can influence like the survival for this filling. For example, if patient is younger, for example at 25 years, how it's going to impact on the survival rate of this filling material. For example, it might be possible like the age who has a 65 year, they are going to have a short-term survival rate for their filling, and the people who are younger, for example 30 year, their filling can be long last. So these kind of answers we can use this methodology to answer these kind of questions. So there is some pro or cons. So there might be a simple question why we will use the simple regression analysis for doing, for example, logistic regression or some another method to doing this analysis, because this is a time to event data, and this is a unique because the outcome of interest is not only whether or not the event will occur, but also when the event will occur. So it is not like whether there is a correlation between the filling and the age, but also like how the filling will be the long last. So this is why we are using the survival analysis. And in the similar thing like traditional machine methods of the regression analysis, for example, logistic regression and linear regression are now suitable for both event and time related aspect to outcome in the model. And the traditional regression method are not also occupied to handle the censoring. So what is the censoring? The censoring is a very, very important part in the survival analysis. So suppose in our case, our analysis is start from 2015 and goes to 2021. So there should be a certain limit of the analysis. If you are doing some drug trial or anything, then the trials cannot go long lasting. It should have a certain limit for the trial. So suppose for one trial, there is a limit of 2015 to 2021. Now some patient is admitted in 2015 and they goes to 2016. And after that, we don't know what happened with this patient, whether the patient is died or they excluded from the study or any external factor. So these kind of events are censored. So a complete event can be from 2015 to 2021. That is, you can say it's a complete event. But in these particular time duration, there are lot many events which are like not complete. For example, they did not reach to 2021. Some may be died between 2016, 17, 18. Some may left the study around this time. So these kind of events which we call the censoring. So we have to take care about the censoring, which is not applicable, which is not like the traditional machine learning algorithm or the statistical a method, for example, a logistic and linear regression or other GBM regression methods can handle. So that's why we are using these survival analysis for this study. Now, there is some cons also. As I mentioned, you should be well aware about, while using the survival analysis, three things. What is the event? What is the definition of time? And what is the censoring points? So if you get confused between the time, event, and censoring, then you will not get a right conclusion from the survival analysis. Otherwise, survival analysis is very useful. It has a graphical interpretations of the plots, which you also need to careful about why you are interpreting the plots. So, what is the outcome in our studies? The outcome, or you can say the event of interest, is the primary outcome we have. And we define the event of interest as a status is 1, those who have a 2 plus long-term condition, 2 or 2 plus long-term condition, and 0 for those who don't have a 2 or 2 plus long-term condition. So the status of proxy measures the healthcare need, as we know that people with 2 plus LTCs tends to have a greater healthcare need. The status may be changed as the people age, as we followed by the people over the time of 2015 to 2021. So what kind of survival analysis or survival method we use? There are mainly 3 kinds of methods are there, and I will quickly go through those. One is Kaplan-Meier, other one is a long rank test, and the third one is the Cox proportional method. In the Kaplan-Meier curve is a graphical representation of survival function of likelihood estimation, and this likelihood estimation of having, in our case, like fewer than 2 plus long-term condition along the different time of interval. And the Cox regression model, is compare the hazard of different group controlling for age, gender, deprivation, and ethnicity. If I'm take the same example, for example, the example which I'm giving for the dental filling. So how we can explain the Kaplan-Meier? So on the y-axis, you have a probability, and in the x-axis you have a duration of the time. So you can check on which particular year, or for example year 1, 2, 4, or 5, how much is the survival rate for your filling is there. So you can simply draw that. And why you are Cox regression model? So suppose if you want to make sure how this survival rate is gonna affect on the other variables, for example patient age, patient gender, or patient deprivation. So this is why we are using the Cox proportional hazard model to explain what is the effect of those variables there. And of course, like we have done the censoring method, because in our study we don't have like clear information about if whether the patient is die or patient is simply left between this duration of study. So this is why we are using the right censoring method, which is the most common method to use when you have a lot of confusion about, or the data is missing there to decide whether which kind of censoring or which kind of censoring you should use. So as I explained how the survival analysis can be explained, it can explain by the Kaplan-Meier plot, and this is the best example here. As you can say, this is a time to event analysis. So here you have on the axis years 1, 2, 3, 4, 5, 6 to 12, and then you have another axis which mentioned like the number of the candidate has done during the prime ministership of different prime minister. As you can see, the most of is the Boris Johnson has, like in year 3, he has a 46 as the maximum number of resignations are there. So how we can more explain this plot? If you go to the right side here, then we have an year 1, year 2, and year 3. And then this is the survival rate of the Boris Johnson prime ministership. So you can see at the year 0 gets 100% survival as a survival rate for their prime ministership. And then Boris Johnson is went to ICU due to the COVID, then his survival rate is getting lesser, like around 90%, you can say. Then the Partygate happened, and which is the very significant event happened during his prime ministership during the year 2. So this is how his survival rates get dropped down. And after getting lot many resignation from different ministers, his survival rate got 0% in the year 3, and this is how he's not a prime minister anymore. So this kind of analysis, this kind of example we can explain similarly in our case for the long-term conditions. And now I'm gonna hand over to Ihan for explaining our findings related to survival analysis.
Thank you very much, Santosh. And yeah, now after understanding the context of our research and the method we use, now I'll introduce you to the finding. So although that Santosh just showed us a nice way of interpreting Kahneman plots, we can still sometimes get confused about the slope. So here is just another example to give you a very good sense of what it represents when you're reading the plots. So on the left-hand side, you can see, again, the x-axis represents the follow-up years. The y-axis represents the hazard of survival. So if you look at a graph that is purely almost horizontal, then that means this person or this population is almost immortal, like the elves. Well, if you look at a graph that is almost vertical, then it represents that the survival is really bad. It's like bluebells die in a year. So this just gives you a general sense. And now let's look at the results in detail. Our first question was what's the general aging patterns of people in Northwest London? And here shows the overall pattern. What we can immediately see is that in the beginning, the job and the hazard of survival is quite small. However, it became much larger at year 7. So this really indicates that although the risk increases with age, the relationship is not linear, and it kind of widens as time passes. And if we look at how the patterns differ by gender, we can see that the difference is almost negligible. The females and males, they follow almost exactly the same trend, and slow, very gradual change and then sudden drop. So that is quite consistent by age. If you look at the patterns, how it differ by age group, then we can see that in the first 3 years, all the lines are almost overlapping. So there's little difference between the age groups, except for the age 85. This is maybe one of the biggest caveats. That is, there's a certain level of selection bias because whoever were included in the data set that lived up to 85 tend to be the fittest and healthiest. That's why they tend to have the kind of best survival curve compared to other age groups. But if you look at other age groups, it's quite obvious that the younger age group, they tend to, their risk of having experienced momentary long-term conditions is actually smaller compared to the older age groups. And the difference started to emerge after year 4. So if we look at how the patterns differ by deprivation level, our first impression is that it's quite similar to the difference by age group, except the difference is smaller. That is because we know that deprivation level is an area-based character. It's not like age, gender, which is individual level. So that's why we observed a smaller difference between the groups. However, the general patterns is probably not surprising that the people living in the areas of the higher deprivation are more likely to have greater hazards along the year. And again, we observe this gradual and then sudden drop of survival. And if we were to quantify the risks, we can read from this regression table from the Cox regression modeling, where we controlled for all those characteristics. So as you can see, and for each variable, the reference group is the group with the least risk. So it's female, 65 to 66, white, and less deprived. And if you look at the hazard ratio, you can tell there's quite some difference here. So people who are older and who are Asian and Black and who are living in the most deprived areas tend to experience the long-term conditions earlier. So what we can learn from this research, first and foremost, we can observe that the onset of having more than 2 long-term conditions among the older people actually differs substantially by the characteristics I just introduced. So particularly among the Asian and Black, and those who lived in the most deprived areas, we observed the highest risk. Although for gender, the difference is quite small, although it's like significant. And coming back to our original series, what we can see is that perhaps none of those theories fit with our empirical evidence. What we observed is not linear increase, that as people age, they experience more long-term conditions. It's actually more nuanced. It's likely that people are experiencing the morbidity at a later stage, and also they're experiencing it in an increasingly severe manner. So like in the first few years, it's fine, but after critical point, they suddenly experienced the conditions much more seriously. And we can also, so it's more like a kind of variant of the dynamic equilibrium theory. And what we can also learn from this research is that we maybe, although we can capture, we can use a single graphic representation to describe the underlying population, we actually, each subpopulation may have their own trajectories. So the same trajectory might not be applicable for all the groups we're interested in. And we also learned that probably for those people that are that are at the highest risk, we need to have this target preventive interventions to delay the onset of the critical age. And yeah, so that's basically the lessons we learned. And obviously our research is not without limitations. Our data set was just based on Northwest London, so it's not comprehensive, and it only spanned about 7 years. And we know some data set, some longitudinal data set, they can expand for more than 30 years. So ideally, we would like to replicate the findings there. Another limitation is that we use the number of long-term conditions as a proxy for people's overall health needs. However, we know this proxy is not perfect, and because people who are more conscious of their health needs may get their long-term conditions diagnosed early, so there is some degree of confounding there. But overall, I think the findings we find is quite consistent with other similar research. So yeah, we would see we have some confidence in the findings we find. So now we've finished the main content of this hurdle, and we can open the floor for questions.
Hi, thanks very much for that, both. That's really a really interesting project, really interesting findings. Some of it seems to, I guess, chime with what we feel and know, but like you say, there's that nuanced understanding, isn't there, of the actual timing and those specific cohorts where the changes are different for those 2+ risk factors or morbidity things. Let me just see we have any questions. Well, we have somebody pointing out very rightly that they loved the Bojo illustrative, so that went down well. Thanks very much for that. Someone's sort of jumped in on where you mentioned, I think it was in the recommendations, about these targeted interventions. This was probably not within scope of what you were looking at, but did you have ideas on what those targeted interventions would be, or is that next steps? Is that for others to consider? What's the answer? How are you going to mend this?
Yeah, thank you very much, Rachel. I think you summarized very nicely on behalf of us. Indeed, it's our next steps as we first need to ensure that we have the findings right, and then we will need to find ways to apply this. So obviously we're looking at this, and we can get back to you later.
Yeah. Okay, with the answers, because I know we've got lots of public health people in our audience today, so some of these sort of interventions approaches will have been sort of considered and are active and have been for many years, but it's just anything to enhance the understanding of who to target and with what is always very useful. So that's great. The other question I have here was, well, it's not a question. Someone says, thank you for a really interesting presentation, and they like this approach. So that's great to see as well. I've got a hand up, and I think it's Jason. Jason, you have a question?
Hi there. Yeah, this particular work of interest to us because we've been looking at sort of similar work, looking at what escalators of care. I'm curious why you've just looked at 60 and over, considering that there's quite significant early onset of disease, and especially 40, 50-year-olds. And when you talk about intervening in age groups, really, you wouldn't really intervene in 65-plus-year-olds because the interventions needed to prevent them developing these conditions probably start way earlier than that in their life trajectory.
Yeah, but for us, it's like because Real Center guys is looking for, particularly for the aging population. This is why we have included only the 65+ population there. But yeah, I'm completely agree with you. We should consider 45.
So Jason, just would you like to share with presenters what your role is? And so, because I know that this is very much your bag.
Yeah, so I'm a population health analyst at the Population and Prevention Health Unit at New Cross Hospital, which is part of the Royal Wolverhampton Trust. So I work across the hospital and the public health team in Wolverhampton.
Yeah, and thank you very much, Jason, for your question. Indeed, as Santosh mentioned, there was a methodological limitation that this is the data set we have access to. So even though we would very much want to include the younger age group, that was not possible. Yeah. However, I would also like to point out that traditionally people would refer to the whole population aged above 65 and consider them elderly and just assume they would be experiencing a lot of poor health. However, if we look at the difference, we can actually see that nowadays the age 65 to 75 actually are not that unhealthy at all. So indeed, this helps us redefine the population health needs. Perhaps we're being too pessimistic about assuming that it's too late when people are aged 65 or over.
I think what we've found with our segmentation work is that there's definitely a substantial number of people who are over 65 who don't have or have one or two long-term conditions. We tend to look at 3 or more long-term conditions. But then you will find considerable early onset of morbidity, especially in the 50+ population. And that's definitely linked to deprivation and certain ethnic backgrounds as well. And also there's gender differences between male and female, which is quite significant. So your question was, when does morbidity on average start in the population? I think morbidity on average in the population probably starts earlier than 60 for a substantial number of people. And then you do then have this large cohort of people who are living in an unhealthy state, but for longer. And that has all sorts of implications for healthcare resources. I mean, if you look at somebody who's got diabetes at 45, they're probably not going to die until 75, but they're going to live 30 years more in an unhealthy state.
Yeah, indeed. I think that it would be great if we can discuss offline about how we can collaborate and make use of the data that you have to explore.
I mean, the other thing I would say as well is that the problem with long-term conditions is they don't really give you a measure of severity of illness as well. So you'd probably have to look at also other escalators such as repeat emergency admission on top of that, because you can have a long-term condition and be relatively well managed for it, especially things like asthma. But some people with asthma will have repeat admissions, which then is totally a different state. So you're not always in the same state. Not everyone with a long-term condition is in the same state. They're all managed at different levels, and not all long-term conditions have the same healthcare utilisation implications either.
That's a very good point. Thanks very much for that, Jason. There's lots of information there. I definitely think you should join up offline, and it will enhance your future work, I'm sure. I'm sorry, David, I completely missed that you put your hand up first. David, do you have a question? Are you still there?
Yes, I am. Thanks. I don't know if can you see me or
I can see you. Yeah. I can see and hear you very clearly.
Yeah, great. Thanks. Sorry, because I don't have access to chat on this. Okay. But I wanted to begin just by saying thanks very much for this really helpful perspective, and I think also potentially a more useful means of exploring morbidity than what we tend to have access to, which is years of life spent in disability or healthy years lost and healthy life expectancy, because those tend to get sort of picked up in census questionnaires and not then repeated for a while. So we have a data set of healthy life expectancy by ward or by MSOA or by local authority area, etc. But that's difficult to measure sort of any improvements or changes over time. But really what I want to sort of explore with is partly the difficulty of using numbers of conditions as a proxy, because as you have demonstrated, you find that people in more deprived areas accelerate faster than people in less deprived areas, and I think that's one of the key observations to any of these sorts of Monmouth curves. But clearly those who have already got, say, one long-term condition when you start, if they are in a deprived area, might actually be well on the way to getting a second long-term condition, whereas those who are in more affluent areas might have only just got one condition, and it will be a while before they get their second diagnosis. So that might introduce an additional bias into how you interpret the results. I don't know, but the other thing was just in terms of the relationship between healthy life expectancy or any other measure and total life expectancy. What you find when you look at small areas, and I don't know, I mean, you've done it by deciles or quintiles of population, and I expect you would find the same thing. If you do a snapshot, what you would find, I think, is that in the areas of highest deprivation, you've got the shortest healthy life expectancy as well as the shortest overall life expectancy, but the number of years lost, or the number of years spent in poor life health, is much greater than the number of years spent in poor health at the most affluent areas. So if you conceptualize life as being, you're born, you spend a number of years in good health, you spend a number of years in poor health, and then you die, what we should be looking at is how do we move people along that curve? And a gradient for life expectancy across different areas is approximately half of the slope of healthy life expectancy. In other words, the difference, say, between maximum and minimum life expectancy in a more deprived area might be 8 years, say, it'll be about 16 years for healthy life expectancy. So if I just show, I don't know if you can see that on the screen. Excellent. As a sort of illustration of our local data in Dudley, for instance, but the point is that the two blue lines are the gradients of healthy life expectancy and overall life expectancy. Mm-hmm. For me, this is one of the most important charts in epidemiology, but I find it very frustrating that healthy life expectancy is so difficult to measure, because what we want to do is to be able to measure change in healthy life expectancy in order to see where we're going with overall life expectancy, because if we can shift people towards the left side of a curve through whatever interventions, then in theory we are improving their overall life expectancy by a bit, but we are dramatically reducing the amount of time that they spent in poor health. And even if you only improved overall life expectancy by, say, a year, if you were to improve healthy life expectancy by 6 months and overall life expectancy by overall life expectancy by a year, what you're doing is you're shortening the period of disability by 6 months, and 6 months less poor health in a context of, let's say, 10 years of overall health is 5% overall of your time spent in poor health that you have avoided. 5% of the NHS budget less spent on long-term conditions is we're talking billions. So how do we measure that more effectively or in real time rather than using healthy life expectancy? And what interventions might we have that could shift people along the curve? Thank you.
Thank you, David. That's really useful. It's good to have your local data as well, which is obviously going to be very similar.
I have done that for Dudley. I have done it by ward, by MSOA, and I've done it for national data as well at PCT level, the old geographical boundaries. And it is exactly the same relationship. It's about double the height of the healthy life expectancy curve is about double the height of the overall life expectancy curve. It's just we can't measure the wretched thing in real time.
Yeah, so, we can't measure it, but it's the basis of so many targets, isn't it? Sure. So that's useful.
So how do we overcome that, building on your methodology?
Okay, that's I think that's quite a big question for our guests today, but also very interesting perspective and information that they can take away for next steps, I imagine. I don't know if you wanted to say anything, our wonderful presenters at this stage. That was a no. I have another question. So I'm going to just. So another question was for you. Thanks again, David. What about the impact of COVID? I mean, this has to be here. So if the study data finished in 2021 was the final year of this, which was the final year of the study, access to primary care and presumably diagnosis would have been affected from 2020. So there's just an observation there. Or a question, maybe to consider.
So we already didn't include like 2022 data because the data was not completed and the data had till 2021. That's why we just considered it 2021. Yeah,
I think the question is really COVID will impact on everything, and there's going to be a consideration when in sort of interpreting. That's my new word for the day, interpreting. There you go. I gave that one for free.
Indeed, you see that the largest job in the 7th follow-up year, so that might be aggravated by COVID, but the trend is consistent. So I don't think COVID alone can explain.
Feels robust. So Paul, you have a question. Go for it. You're on mute. Be loud.
Can you hear me now?
I can.
Okay, great. Thanks very much, Santosh, Ihan. That's really interesting. So, not really a question. I just wanted to flag something up for people on the call, really. So, quickly, the strategy unit will be running a project on pretty much exactly this topic. So, the impact of an ageing population on healthcare demand for the decision support network later this year. So the specification for that work is still being finalised, but I'd expect that there should be some details on the MDSN website within the next few weeks about the nature of that project. Just to say that the plan is that one of the outputs from that work will be a tool that will allow local systems to input their own healthcare utilisation data, run some models against that data and return results that show the impact of population change on healthcare demand under different assumptions about healthy aging. So how demand might vary under some of those scenarios that Yihan and Santosh described. So compression, expansion, morbidity, or dynamic equilibrium. So really, it was just to kind of flag that up for people, and that there'll be more details on that work coming out shortly.
And is this something you're going to be leading on, Paul?
Correct.
Yes, it is. Actually, and on that note, that's an interesting point I raise, is that I think there is, you're coming to the end of the current analytical project for the Midlands Decision Support Network, and I think we've got you booked in sometime soon to talk to us about that.
Early October, isn't it? I think. So,
marvelous. Yeah, I do believe it's the next Huddle, actually. Yeah, so that's the 6th of October. Fantastic. Well, I look forward to hearing about that. Thanks very much, Paul. Okay, so I don't think we have any further questions for our presenters. Did you want to say anything back to Paul, Yihan and Santosh, or shall I move on and tell everybody about training opportunities?
So Rachel, I have a question.
Sure, Zoe, go for it, Zoe.
And it can be actually for quite a lot of people in the audience as well. I'm particularly interested in mental health data, and I know when we look at this kind of information, we're looking at comorbidities, but the issue I'm tackling or like considering is mental health issues shorten people's lives. So is that as a result of comorbidities, and does that have the same effect? Or is this a cohort that is just affected by their mental health condition? And I suppose the thing is they'll be in your data. And also in terms of COVID, there's a relationship with neurological conditions. So it may be that could increase too. We might not be seeing it now, but we might see it in this older population as people age. And it's just, has anybody ever looked at mental health conditions specifically, separately to physical? It's like, is there one condition that is more affecting of people's lifespan or general health than others? And when we look at it, we tend to always look at physical health needs. So the more you have, the more difficult it is kind of like the message I'd pick up. But you might just have one thing, which is a severe mental illness, and then that could be the thing that affects you totally. So has anybody looked at that? You're nodding, which is really good.
Santosh, do you want to come in and answer?
Yeah, so I think this which one is that?
Yeah, so in the data setting we have like 14 to 16 categories of long-term conditions, and mental health was one of them. But obviously, we couldn't look at things that specific, that details. But this could be our future projects or future collaboration if you would like us to look further into this.
But do we have the data?
Yeah.
Yeah, do you have the data? That's the thing with mental health, isn't it? And it's a big range.
People might not be going to the acute hospital, so you might not be seeing them, but they could be acutely unwell physically. Yeah. And I think there's a disconnect. So it's a bit of a gap in our data knowledge, but also an understanding of what data, how to find those individuals. I was talking to somebody very recently today, about alcohol dependency. I had a neighbor who was very, very dependent, would go frequently to hospital, but not because of the alcohol dependency. It would be other factors which probably are related to it, but falling over, breaking your arm, just funny turns, dizzy spells. It may be coded, but it won't be the main code, but there's attributable in terms of public health in the conditions. So it's kind of hidden, but it's in plain sight, because you ask anybody in A&E, they'll say that they're getting people who have difficult mental health conditions, and they kind of get taken to specialist areas. But I just wanted to sort of plead that, this is an area that's really tricky, but please don't shy away from it.
Definitely, and very, very important area. And I think the strategy unit have done some really good work with mental health and reports as well. So check that out. I'm going to thank our presenters again. I'm just going to move us on for the last minute. I'm determined to end on time today. I was like 1 minute over last time. Now I blame Zoe entirely for that. So thanks again, guys. If I've got any questions that I haven't managed to raise with you, I'll do it after the session, and then you can respond. Thank you again for. I've gone on to 12 now, so I'm not going to have a chance to talk about the training opportunities, but that's fine. I just wanted to say you've got your away day. You've had fun already with Andy Olowski and team. Enjoy the rest of your day, and thanks so much for taking a break from that. Do appreciate it, and we'll see everybody in approximately exactly 2 weeks time minus an hour. Okay. See you guys. Bye. Bye.
Thank you.
Thank you.